At Atma Clinic, we're challenging the way insurance companies dictate your healthcare, limiting choices and rushing treatments. We believe in a different approach, one that puts you, the patient, back at the center. That's why we've partnered with Brad from King's Pharmacy, a local compounding pharmacy that customizes care for those left out of the one-size-fits-all system. Join us as we talk about how this partnership is redefining healthcare on our own terms. In a world dominated by Big Pharma, we're here at King's Pharmacy, where personalized care takes center stage. Let's step inside and see how they're revolutionizing medicine, one prescription at a time.
Welcome to King Pharmacy. I'm Brad Grant, and I'm going to give you a tour of our compounding pharmacy. So this is our lobby here, where we have some different, just various over-the-OTC items for pharmacy, as well as our supplements over here that we offer. We do like orthomolecular brand, and we also have some other brands as well that we offer for nutritional supplementation. Coming on back, pharmacy here. Then we have our supplies here that we use to fill the prescriptions. And then the main compounding that we do actually takes place back here with the clean room, where we do the sterile product. And we have our pre-room here that we use to prepare the sterile product. We have an autoclave. We have a powder hood here to do the sterile, to prepare the sterile products before we sterilize them. And we have incubators here to test for sterility. We have the anteroom prior to going into the clean room, and we have the hood that we sterilize the sterile products into. Here is our compounding lab. And here is where we prepare our non-sterile products. We have all kinds of different specialized equipment we use to make these products. NAS mixer here to make sure that we get the powders mixed up thoroughly. It's kind of like a glorified centrifuge. Then we have the dry clave that we use to sterilize, like dry heat, or to melt down product, like if we're making suppositories or cooking, like the rapid dissolve tablets. Through here that we use to mix up the creams. They're like mixer here, homogenizer, that we use to mix up liquids. That kind of breaks up all the particles and gets them into a really fine suspension. We have the powder hoods that we have to compound the products and weigh them out with these very sensitive balances. Kind of get everything cleaned up again and ready to reuse the different dishes and beakers and things like that. Our supplies of chemicals and liquids that we use to make the compounds. And then that's pretty much it.
Hello everybody, I'm Dr. Sandal, founder of Atma Clinic, where we are all about personalized healthcare. I am joined today by my friend Brad Grant, who is the owner of King Pharmacy here in town, a local compounding pharmacy. And their emphasis is on helping people get creative solutions when the generic Big Pharma approach isn't getting people what they need. Brad, thank you very much for
having me. I appreciate that.
Happy to have you on.
Well, thank you. So yeah, we do compounding pharmacy. We've been doing it for 18 years now. I've had my own business, and I've been in the business for 24 years. Love doing the compounding. We basically our kind of our gist of where we fall into the healthcare spectrum is that we help the people that fall through the cracks of healthcare. So when they aren't getting help from mainstream medicine, then that's where we usually come in. But then a lot of times we can also do, like, if people are like allergic to certain components, then we can compound that. Different dosage forms, we can combine dosage forms. We do all kinds of different compounding. We do pain management. We do hormone replacement therapy. We do like veterinarian compounding. Several different components of that.
One of the things that I think is great about compounding pharmacies is that there is not a one-size-fits-all, and so much of the pharmaceutical industry is geared towards, can I say, merchandising, right? The sort of like, how do we maximize profit?
Right.
And so we're going to produce a amoxicillin in this particular format, and we're just going to spread that everywhere. We're going to distribute that through CVS generic pharmacies, and it's full of all sorts of, frankly, insane additives. You know, I'm thinking about amoxicillin suspensions for children, the bright pink liquid.
Right.
It's like, well, why is that bright pink, guys? Like, what did you put in there? And the answer is they put in a bunch of horrible stuff. But it's just the way they do it. They have a sort of scale that they think gives them the best profit margin.
Right.
And it doesn't really have much to do with what is good for the patient. And so one of the things, for instance, that I would love to send over to Brad is, hey, I need this medicine without all of the petroleum-based artificial colors. Like that is, like there are many people who become ill from those things. And so why do we put it in our medicines is kind of mind-boggling sometimes.
It is, and actually to speak to that specifically is that the reason why they do a lot of these additives is because it has to have a shelf life of many years for it to be profitable for them. And not everything that they put in there. Some things you are as a head scratcher for why they put that in there. But but you know, the thing is that, you know, they have to be able to get something and then have it out on have like a shelf life of a long time for them to be profitable for them when they make these batches. So
that makes sense.
So they're mass producing these things, and so then, you know, the other thing to speak to what you were saying is that they can only do so many strengths to come out with,
right.
because then they're going to say, okay, well, that will basically cover everybody, but you know, it's like it's not, you know, specific for each individual, and that's
Right.
where something where we could come in and we could say, okay, well, we can do an exact dose for that body weight. We can do an exact dose for this particular circumstance. You know, pretty much everything we do. I mean, we don't put any food dyes in there. We don't. You know, the only time that we, you know, really put any additives in there was when it's absolutely necessary to do so. And you know, there's so many people that we have come in that have like allergies to so many different things that we are able to accommodate that.
Yeah, one of our favorite things at Atma Clinic, as many of our viewers know, is getting people off medicines. And you're exactly right, Brad. You know, if we're trying to get someone off, let's say an SSRI, an anti-anxiety, antidepressant medicine, there are certain standardized formats. But what I would really love to do is to be able to slowly down titrate that, bring the dose down very gradually, and getting around the sort of standard dosings of those can be super helpful for that. So I always love communicating with you guys and saying, hey, you know, is there a way we can make a quarter dose of this or a half dose of this? Like, how do we bring this down in a way that best fits this person's unique biology? And that's definitely outside the realm of mass production, right?
Exactly. And now what you're talking about is actually practicing medicine. Because now
God
you're
forbid,
and you're sitting there saying, hey, you know, I have this patient and I'm treating them as an individual. I'm saying, hey, they need this specific individual treatment. And then you're calling me up and you're saying, hey, this is what I'd like to do. And then we can sit there and say, yeah, you know, like we can like, you know, go back and forth and say, okay, let's come up with a dosage form, let's come up with a strength that works for that patient. And that's the big difference there. So then, you know, you're thinking outside the box. You're thinking, how can we be more effective with this patient?
And that's the sort of collaboration that used to happen between MDs and pharmacists all the time. And I think most doctors and probably also pharmacists have a sense that things are rather antagonistic now.
Yeah.
And you know, I remember talking to a pharmacist who works at a CVS, and we were talking about the sort of strangeness of corporate pharmacy. A lot of the decisions that they would like to make as independent, well-trained practitioners are limited by their brand. You know, CVS has certain things that are allowable and not allowable.
Exactly.
And so a lot of times physicians will phone over there and be like, hey, I need help with this thing or whatever. And I think patients also have this experience. The pharmacist will say, I can't help you with that.
Right.
Like, well, why not? And you talk to me about that.
Yeah.
I'm like, well, we just don't do that. And it's like, you mean you as a professional or CVS?
Well, it's refreshing when we come across, like, you know, physicians or practices that they are willing to sit there and think about the individual and then how can we treat them, you know, better through, you know, alternative methods. And, you know, what we see a lot of times is doctors that are afraid to go off reservation as far as like, you know, well, you know, if you have this, you do this. If this doesn't work, you do this. If this doesn't work, you do this. And I feel like that a lot of times, you know, and then again, the other problem that they have is they only have like 5 minutes to spend with a patient.
Right.
And so now you're like, do you really have the time to really understand what's going on with the individual in this case? And, or they sit there and say, okay, well, you're playing the percentages and you're saying, well, this is the thing that percentage-wise would work for most of these people.
Right, that's statistical medicine.
Yeah.
Yeah.
And so they say, okay, well, statistically, this is probably going to work for you.
Right.
And then instead of sitting there saying, well, what is really going on with you? Uh-huh. And so then because they haven't been trained in, thinking outside the box and thinking, okay, well, treating an individual,
right.
Then that becomes a struggle for them to say, or a comfort level from a standpoint of saying, well, hey, let's reach out and let's find out what we can do.
Right.
For the, and I think for a lot of people, they're worried about, going off reservation, getting on board with in trouble with the Board of Healing Arts, or if they're, going to be, called up for like a lawsuit or something like that, and I think that, dialogue between, compounding pharmacists and doctors, I think that could, that sort of thing can be alleviated because, we have the expertise in one area and then you and a lot of your fellow practitioners have expertise in another area. So it makes a good combination.
Good team.
Yeah, synergistic.
And we need more of that non-mass produced thinking. This is true in medicine, this is true in pharmacy, this is true in agriculture. We need less mass production because it net gives an inferior result. And I like the way you were describing that. They're playing to the statistics.
Right.
If someone comes in and they have a head cold, there's a particular algorithm that MDs are taught to run people down. And nowhere in that algorithm is Neela or Brad. Right, again, they have 5 minutes, they have to hustle, and then they go, well, this is the result of the algorithm, go to CVS and they'll get you filled up. I'm calling out CVS a lot, right?
Happens, yeah.
And
that does happen.
Right, it happens all the time.
Yeah.
I mean, dare I say tens of thousands times, hundreds of thousands times a day, like in the US.
Yeah.
And nowhere in that is the individual brought into this. And that's really, really important because medicine and pharmacy should fundamentally be individual things. If we're going to do maximal effort.
Maximum effort.
If we are going to do the best thing for Brad or for Neela, we have to pay attention to us as individuals. What are our unique factors? And so, again, mass production, it's got its benefits, right? It can drive down costs, but it is always and inevitably at the reduction of quality. There's no question about that happens. And so people who want really good healthcare or really good thoughtful medicines have to come to someone who's doing that bespoke to them. They have to go to a compounding pharmacy.
Right.
Yeah, it's tricky. I mean, I can understand how we got here, but at the same time, it kind of is frustrating.
Yeah, I can totally understand that being the case. And, actually we have a lot of people that come into our practice that have been to a doctor's office and they're frustrated because they aren't getting the results because they're getting played the statistics on that.
Yeah.
And so we'll have family members come in and say, hey, I've got a family member they've tried everything and they're not getting results, and they'll be saying, is there anything you can do? Or we'll have them, actually the patient, come in and say, hey, I've tried all these different things. Is there anything you can do? And then we'll spend the time and we'll go through and say, well, tell me what you've been on. Tell me what's going on with you.
That's awesome.
Dig a lot deeper and say, okay, well, then all of a sudden, when you're asking all these questions, many times, if not all the time, the picture becomes very clear.
Right.
Of what's going on with that patient. And then you can sit there and say, oh, okay, well, we could do this, we could do this, we could do this. And then we throw those options or an option out to the doctor's office and say, hey, this person came in and they've had this problem, and, I know you've tried this and this and this. But we would suggest maybe trying this, different
That's
approach.
a deeper level of medicine. That's a deeper level of care.
Yeah.
It's great.
Yeah, and so that's, we don't, we actually like it, when like for instance yourself, that you call up and you're already going that extra step, and then now we're not really trying to figure out necessarily, even though we would throw out ideas to you that maybe might work, but having the dialogue already at another level where you can sit there and say, okay, well, hey, I was thinking about this. Okay, yeah, that sounds good. Or hey, how about this? Or how about this and this? And that's such a great collaboration.
Yeah. Well, and I wish that more patients were particular about getting quality health care. There is so much a culture of acceptance. For some reason or another, patients have the idea that they go to the doctor's office and what the doctor says is the thing.
Right.
That is it. That's what's on offer.
Right.
I think as a culture, people have forgotten that we are all scientists trying to evolve the science over time. The science is not a finished product.
Right.
Nor does a single doctor know everything, even about their specialty or a particular disease condition. And so having that self-advocacy from the patients is something I'm always advocating for. I'm always banging the table, being like, listen guys, be fussy, demand really good health care.
Right.
And having connectivity with a pharmacist team at a compounding pharmacist who can augment the physician and the patient, it's another leg on that tripod for really good individualized care. That's a good care team.
Right.
The patient leads that, the physician helps do detective work, and then we're able to talk about what sort of innovative therapies can we get into with you guys.
Right.
That's just exciting to me. Like, to me, I'm like, okay, good, now we're getting somewhere.
Yes.
Now we just have to bang the table and get up on the rooftops and yell about it enough that people go, oh, geez, maybe I shouldn't just take a Z-Pack for every viral infection.
Yeah.
Or maybe I shouldn't just rely on this X, Y, and Z.
Yes. I totally agree. And, when something like that happens, it raises the level of healthcare so much. Because now nobody worried about a turf war.
Right.
Nobody's worried about lawsuits getting called up on Board of Healing Arts. Mm-hmm. They're treating the individual. They're going to get great results when they do that and they get that collaboration. And sometimes the cookie cutter approach is going to work great. And obviously these big pharma, these drug companies, they've figured out that if they do they crunch the numbers and they've done a cookie cutter approach and they're saying, okay, well, if we give them this options, it'll cover enough people. So it'll cover the majority of the people, but then the people that aren't part of the majority, it's a problem.
Right, and who's not part of the majority? Well, 49% of people are part of the majority, right?
Yeah.
So that's an enormous amount of people. It's not that the big pharma approach to healthcare misses rarely or sometimes. No, it misses all the time. We've just come to be acclimated to that failure. People just go, well, people talk about the lack of trust in their doctors and in the healthcare system.
If the water's not drinkable, if the tampons have lead in them, if the fucking American chickens are made of GMO plastic, the strawberries have red 40, and then I'm going to the hospital, I'm going to the doctor, why is my hair falling out?
I just saw a study showing that 31% of Americans trust their doctor.
Right.
31%.
Yeah.
Nobody trusts their doctor. 2/3 of people don't trust their doctor. And they're like, well, why does that happen? How have we ended up in this place? And it's because of the sort of mass production illusion. It's the culture of one-size-fits-all medicine that frankly doesn't work. And you make a nice point, yes, it does work sometimes. But as people become increasingly chronically ill, as our health system fails and crumbles, more people have more chronic illnesses and become more so outliers. So that standard medicine begins to work even less and less and less. And I tell people, just hit the eject button. Just go into a different medical paradigm that is going to see you as a human being and actually come up with solutions that will work for you. And
well, when I worked as a regular retail pharmacist, I would see elderly people come in. They'd be on 24 different medications.
It's common.
Yeah, it's real common.
Yeah.
And I'd be thinking, oh my gosh.
Yeah.
24 medications. And some of these medications are treating the problems from the other medications. Mm-hmm. And there's
that term, prescribing cascade.
Yes.
I think that's very evocative.
Exactly.
It's like a waterfall.
Yeah, polypharmacy.
Right.
Yeah, it's different phrases. But I was sitting there, and that's one thing that started getting me interested in doing, compounding pharmacy, is that you look at this and you look at the people and you look at the outcome, and they don't get better.
Right.
They get worse.
Right.
Yeah.
Brad, what are some common medicines that you will compound? What's kind of your guys' favorite stuff for your bread and butter, or what do you see all the time?
Well, we do a lot of hormone replacement therapy, and that's one thing, when I first opened up my practice, is that there was so many, women out there that they knew something wasn't right, but they didn't know specifically what was going on, and they thought it was just them. And so then I brought in a national speaker to talk about the subject, and it was amazing how many women that came out. We had a great turnout, and they were sitting there saying that I just thought it was me, and I thought I was crazy, or I thought that I was just the only one that felt this way, and it was such a relief and an eye-opening experience for these people to realize that it wasn't just them, that there was help out there for them, and how much that we've been able to help that particular spectrum of the healthcare.
And advance the science on that.
Exactly.
Right? When we get out of the mass production, all of a sudden we're able to get much better results, both as far as reducing the side effects of hormone replacement therapy, but also for the overall efficacy and method of delivery.
Right. Like the other day, we had somebody came in and they had trouble with, are you familiar with geographic tongue?
Yeah.
Okay, so they had geographic tongue, and so, and correct me if I'm wrong on any of this, but she was asking, hey, I've been seeing a doctor about this for several months and didn't get any relief, and so I started asking some more questions about it, and she said, please, if you can come up with something, let me know. And so I did some research on geographic tongue and some different things going on there. And so we came up with this trochee that she could use to get relief, from the discomfort and the burning sensation. And in 2 weeks, her tongue was almost completely back to normal.
That's awesome.
And she'd been doing it over 6 months. She'd been getting treatment otherwise.
What's in the trochee?
It was clove, zinc, and aloe.
All right. Yeah, that's great.
Yeah.
Yeah, that's outside the box thinking, right? None of those are in the realm of mass production pharmaceuticals.
And that's something that's not like, it's not like creating, something earth-shattering, but sometimes it's just the little nuanced things that you can do that make a huge difference.
Yeah. Well, it's nice. People have forgotten that a large amount of our pharmacopoeia came from herbs. And so when we think about something like geographic tongue, which is a sort of modeling of the tongue where certain areas are particularly inflamed and raised, and so it looks like a topographical map, hence a geographic tongue, the question is, well, what is the root of that? And oftentimes the root cause of a geographic tongue is biome dysfunction. And what is happening there is the bacterial species in the mouth and also in the gut, because these are, of course, interconnected, end up creating chronic inflammation. And clove in traditional Chinese medicine and Ayurvedic medicine is a well-established antimicrobial. And so you guys came up with a really brilliant solution to say, well, all of these, zinc, clove, and aloe, have antimicrobial properties.
Right.
Let's apply them topically, aggressively, and there's basically no side effects to those things. I mean, never say never, it could be overdone.
Right.
But that's a brilliant solution.
Yeah.
So what did her doctor think about that?
So they were reserved at first. They were like, well, where did you, what is this? Because I sent over the recommendation to them. And then she, was under the impression that the patient was doing well, what she was doing, but she wasn't doing well. And so she had an appointment with the doctor.
Before starting the trochee.
Right.
They were like, oh, this is not a problem.
But, I feel like, again, it's a lot of times they're a product of their training.
Absolutely.
And this is a very fine doctor that I'm, referring to. But she was somebody that had been trained, the regular, approach to mainstream medicine. And so she felt a little uncomfortable about it at first. Well, she ended up having an appointment with that patient that Friday, and that's why I sent it over ahead of time so she could have time to look at it ahead of time before she met with the patient. And then when she met with the patient, she realized, oh, the patient isn't doing well on this. Then she was saying, okay, well, let's give it a shot.
Yeah.
And so
good for her.
Yeah. So that was, but the other thing too is, I felt that they felt like it was an acid reflux problem.
Interesting.
And so and what we're seeing, and I don't know if you're seeing this in your practice, but we're seeing a lot of people that have osteoporosis really bad because they've been on antacids.
Well, and that's actually a well-established effect now, right? When these antacids came out, they were authorized for short-term use. That was the initial indication. And it's not that complicated of an equation, if you will. We know that we need acidity in our gut to absorb our minerals, and we need minerals to mineralize our bones.
Exactly.
And so this is not complicated or disputed. It's just something that, to your point, most physicians are the product of their training and their algorithms, and that's what they have time for. I'm fond of saying physicians are almost 201 compassionate, intelligent people, but they just exist in a system that doesn't allow them to do great work.
Right.
And again, it works for many people.
I would totally agree with that. The doctors are very intelligent and very good people, but they have been put through a system that they've been kind of in a way indoctrinated into like a system, and they're giving no really opportunity when they get out in practice because they have that 5 minutes to spend with somebody. And I feel bad for them because they're very capable, very intelligent people, and they just aren't being given the opportunity.
Yeah. And so, you're right. If someone covers up a geographic tongue with an acid blocker, we're going to have other downstream effects. And this is part of that sort of polypharmacy or that prescribing cascade where we end up with other problems because we're not solving the root problem, and therefore we continue on a pharmaceutical that has pros and cons.
Right.
Best yet, solve the root problem, get off the pharmaceuticals, and then inevitably age strikes and something else comes up. Well, again, let's get that off our plate. Let's not just manage that and wait for the next thing to dogpile on.
Right. And so, what comes to mind to me is like the Hippocratic Oath that you take, where first do no harm. And so, I feel like you got to give the body the ability, because it's very powerful at being able to heal itself.
Yes.
That if you give it the building blocks or the components to correct course, that it's many times going to do that. And it may not all the time, but in a case where I was mentioning this geographic tongue treatment, it was something where we were first going to do no harm because the zinc, the clove, and the aloe wasn't going to harm the patient. But it had, for what her condition was, had the tremendous capability of being able to have a very effective treatment, and it was very effective. So
Brilliant.
Yeah.
And so do you guys then ever publish that or disseminate that information? Because that's really wonderful information. I bet there's a lot of MDs who would love another therapy for geographic tongue, because to your point, and for this physician who didn't focus in on that, it's not an area of focus for physicians. People see that as a secondary issue.
Right.
And it's like, well, hey, if there's something that we can do for this that is purely harmless, and it's clearly effective.
Right.
Would you guys like to know about this? So do you guys have any methodology of sharing that?
We do. We try to get the word out, when there's different situations like that. I think, again, you're going back to their time frame of how much time they have to spend with every patient. If you go out and you try to, stop by and say, hey, can I talk to you for a few minutes? And go over these different options with them, that they are so busy that they don't really have the time to do that. And again, it's just kind of evolves into itself. And so we try to get it out there. We have had other times where we have helped a patient and they've tried everything. We had somebody that was hospitalized and they were having tremendous leg pain, and so we compounded this cream they could rub on the lower leg. And they had put them on like a lot of high strength opioids. Yeah,
systemic. Rather than getting to the thing, they're just going, let's hit everything.
Right. And so when we did this, and actually the people that came to us about this were the relatives of the patient.
Nice.
And so
it's
then
good to have advocates.
So then when we got the great results, immediately it got better. We were thinking, okay, well, this will be something that will be, a thing down the road.
How do we spread this out?
They'll be able to prescribe this, and they'll take note of it. And it was kind of like, it was like, well, I'm glad it worked for you.
Right. Yeah. So I'm moving more in my career into the phase of training and
Right.
teaching and lecturing. And so right now I'm finishing off training on one of our nurse practitioners and one of our MDs. And they both asked me a very excellent question to which I didn't have a great answer. They said, you know, Dr. Sandal, you're able to get all of these really phenomenal results. You're able to cure things that are thought of conventionally not to have cures. We routinely are able to get remission in autoimmune dysfunctions that are not in standard medicine thought to be addressable issues. The trajectory in traditional medicine for most things is, well, let's keep this managed. No, we just had a case of a very severe, rare autoimmune dysfunction that is now biopsy proven resolved at this point. So we can get into these things, and we do that, of course, all just with personalization, with literally bespoke, individualized science.
Right.
We're strictly speaking physician scientists. That's how we do what we do. And so my students were asking me, they were saying, well, this is a really big deal. We have to publish on this. And one of the funny things about the discipline of medicine, the specialty of medicine that we're in, and it sounds like this is true for you guys in your bespoke designing of pharmaceuticals for individuals, solutions for individuals, there are a lot of us that are doing things that are not thought of as usually accomplishable, right? Like an MD doesn't hear geographic tongue and thinks, oh, I can solve that.
Right.
An MD thinks, I wonder what that's secondary to and how do we manage that?
Right.
So there are all these things that are very much pushing the expectations for what we can do in medicine.
Right.
That's my point. And it's hard for us to all publish and share these things. We're able to achieve clinical results. I oftentimes joke, although it's accurate rather than a funny joke. The most common patient story that we get at Atma Clinic is, hey doc, I just got back from Cleveland Clinic and Mayo Clinic and no one can figure it out. Can you solve this? And in 6 months, we're getting dramatic results. I'm sure you guys have seen, exactly like you mentioned about the geographic tongue, this sort of thing all the time.
Yes.
So then how do we disseminate that information? That's honestly the giant challenge right now, because the truth is I'm teaching and lecturing and I don't have time to go get a grant and do a study and these sort of things.
Right.
You guys, I'm sure, are in the same position. It would be amazing if there was an easier way to disseminate this information, because of course the core of science is replicatability.
Right.
I mean, this is a great start, and then can we do it again?
Right.
Thoughts on that?
So my thoughts are is that, you know, like, again, going back to the individual is that every individual is going to be different. Mm-hmm. So being able to do like a statistically significant study, and then also having the funding to be able to do like a large scale study, you know, double blind, all that, you know, I don't, you know, is it really going to be practical? Because, you know, and I feel like as much as I, you know, think that double blind studies, large scale, are great, you know, I look at that and I'm sitting there thinking there's just so many different individual variances there that I'm not sure.
It's not really something that can be easily studied or applied broadly.
Right. And so, you know, people will sit there and say, well, you know, you got results with this person, but is that just anecdotal?
Right,
or
that's
something?
the dismission that,
Yeah. And so then, you know, you go, okay, well, you know, again, it's a situation where, you know, treating the individual and saying, okay, did you get results or did you not get results? And, you know, it's not like for you or for either one, it's not like we're, you know, somebody comes in and they're going to go, you know, well, I've got, you know, this condition, and then you spin the wheel and you, whatever it lands on. I mean, there's science behind what we do.
Right.
And so so sometimes, you know, the, you know, powers that be would sit there and question you, and you're realizing that, you know, hey, that, you know, there is a method to the madness. We do have medical training, and we have years of practice, you know, experience and knowledge. And that's what we're putting to good use.
Yeah. Let's talk about insurance. When we talk about the limitations of the system on pharmacists and on physicians, a big difficulty is the insurance. Right? People have an expectation that their insurance will cover their health care, period. I pay money to these guys, they pay for my health care.
Right.
And nowadays, I don't think it's rare knowledge. I don't think it's unfortunately, I think it's a very common experience that people realize their insurance doesn't have their interests at heart. Physicians often are antagonistic in their relationship with insurance. I'm sure it's true for pharmacies, and it's certainly true for patients. When you guys are designing a compounded medication, how does that work with insurance, and what is your guys's what are your thoughts on all of that? I have a lot of thoughts about that for my own practice. It's very challenging.
So one thing that I would ask you as far as your practice goes is, do you feel like that the insurance prevents you from prescribing the medication that you want to prescribe?
All the time.
So it's
all the freaking time.
So it's interfering with your practice and your ability to doctor.
Yeah.
Okay. And so what we do, with us is that we don't actually bill insurance directly. What we do is we will send in the insurance claims for them. They do pay up front, but we try to keep it reasonable. And so as far as like keeping costs down, we try to consider the components we put into it.
Because you guys are individually mixing all these, so you have an incredible amount of control on that.
Yes, we do.
That's great.
So we are able to custom, so we're making it for the individual. So everything that we make for the individual. Like hormone therapy is a prime example. It makes me laugh that when I sit there and see, drug manufacturers making hormone replacement therapy, there is no way that drug manufacturers would be able to make the amount of strengths and combinations that would treat the individual ever.
Right.
So
it is so personalized.
So it is so individualized, and so that's a great example of with the difference between going to mainstream medicine, in this case with hormone replacement therapy, and if they don't use a compounded pharmacy to treat this patient, they're probably not going to get great results. They may luck out, and there may be a percentage there that they still hit, but it's not going to be ideal for them.
Right. Yeah. Well, and it would be lovely if we existed in a world where insurance worked with all of this. We're in the same boat, right? We have a cash practice entirely because what we do is beyond the standard of care.
And when you look at the amount of money that people are paying for these, and then the deductibles that they have, it's astronomical these days.
It is insane.
And so, you have to look at that and say, okay, well, I could go to a practice like yours and pay cash, and I would still probably be ahead.
Right, and that is the reality.
Yeah.
One of the things that we've gotten into recently is that we help advocate for patients saving money by switching from big insurance like Big Pharma, to health insurance alternatives.
Right.
And it turns out there are a lot of phenomenal health insurance alternatives that have substantially better premiums, like a tenth of the cost on premiums.
That's great.
And the deductibles are often half or less. Just kind of sane deductibles. Oh, I have a $1,500 deductible this year. Great, that's sane. As opposed to, I was just talking to someone who pays $1,200 a month for their family's premium.
Right.
And they have an $18,000 deductible.
Yeah.
I'm like, that's basically useless.
Yes.
Yes. That's laughably useless.
And what you're doing is you're feeding Big Pharma's, price gouging.
That's it.
Of the American public.
That's it.
And that's crazy.
It's crazy. Yeah. Well, and it's self-destructive. Not only is it non-logical in the sense of crazy, but it's self-destructive in the sense of crazy. In so many regards. And then unfortunately what happens then is the poor patient, of course, feels squeezed, and they're not able to spend money on good solutions for their health.
Right.
So then they get stuck in the system of going, oh, well, I've already spent all my healthcare dollars on my premium. Let me go to a doctor who has 5 minutes for me, and then go to a big box pharmacy that has the standard thing for me, and all that'll get covered. But really, they're just getting their pockets picked while they're not looking.
Exactly.
Very complicated.
Yeah, you're speaking to something that's, we see all the time that people come in and they'll be talking about, well, what's the price of the compounded medication? And once they've had it and they see how well it works for them, and then, the price comparatively, and they're getting the results, I think that the light comes on. And a lot of times people sit there and say, well, I've had women come in and say, I would get my hormone replacement therapy before I would buy food.
Yeah. It can be very, very valuable. Yeah. Good. Well, let's segue from that thought into a big, broad, shiny, glowing topic, the future of medicine.
Yes.
What do we want to see medicine and healthcare become?
Well, that's an interesting question, because it would appear that the hospitals have so much power these days.
That's true.
Over how people are practicing. And so I feel like that's a bad trend. I feel like too much...
There's centralization that can be hazardous.
Exactly.
Yeah.
Centralization is a good word. So much centralization, and then, but what needs to happen is we need to decentralize, and we need to allow individual practices to thrive. And I'll give you an example is like, you can have like, all these like fingers in different pies. But if you're not taking care of even one pie, and then you have all these others, then everything's gonna suffer, and because nobody has a vested interest in that particular practice.
Right.
So if you have somebody that's centralized that owns all these practices, and nobody that's practicing actually has a vested interest, it's just not going to be as good.
So are you talking about the sort of bureaucratic oversight of the clinics under the hospital umbrella?
So let's say like a hospital owns like multiple practices. Well, they're going to have a really good manager that oversees those practices. And then they're going to have really good managers at every one of those locations, or they're not going to do well. And so then, you have like these doctors that are practicing in these practices. Well, if they don't have a vested interest in the practice, it's just not going to be the same as if they own the practice themselves.
Right.
But a lot of these doctors, because the crunch of time that they have, they're going to go, hey, I just want to go in, I want to do my job, I want to go home, and I don't have to worry about my practice after that.
Yeah.
And so
it creates a bad incentive.
Yeah. So then if you have like a bunch of these practices that are under an umbrella that are poorly managed, then the patient suffers from that.
Right.
And the doctor suffers from it too, because the doctor's not able to have a good environment to practice in.
Right. And the doctors, again, they're all intelligent and they all have heart, and so they suffer when they aren't able to help patients.
Right.
And we have a system that is increasingly moving away from that. There's a term that I use, the bureaucratization of medicine.
Right.
There's a joke among physicians. Most of these big umbrellas that are under a hospital that in many regards work for the insurance companies have metrics that are essentially arbitrary, designed not by medical personnel, that are called meaningful use statistics.
Right.
And these are sort of statistical measures and benchmarks that are used by these big bureaucrats and managers on multiple levels to say, oh, if we do this, we're going to get higher amounts of reimbursement from the insurance companies.
Right.
And so what has happened is that many physicians get squeezed by the middle managers who oversee them in these umbrella systems. They get squeezed to say, hey, you have to do care this way. So not only are physicians not being able to prescribe the medicines that they might want because insurance is blocking them.
Money makes the world go round. Money makes the sick boy sicker somehow.
They also are required by their bureaucrats in the bureaucratization of medicine to practice medicine in a particular way. And you better believe it, the satisfaction with that is very low. The joke is meaningless use, right?
And I wonder how many people go through like med school that when they get out and they actually start practicing, and you see this bureaucratization, however you say, sorry about that. That you see this going on, and you sit there and they think, oh my gosh, what did I get myself into?
I would wager that the number is very near 100%.
Yeah.
And you talk to any young physician, and it's hard because, talking about bad incentives and a sort of system that places finances above patient outcomes.
Right.
One of the funny things that happens to young physicians is they come out of med school with an enormous amount of debt. Very much this is a golden handcuff sort of situation.
Right.
In their mind, they're like, oh, if I go and work for the hospital system, they're going to pay me a whole bunch of money and I'll be able to pay down my debt. If I don't work for them, if I do think about going a decentralized approach and maybe making my own practice and having my own style and pushing the boundaries of medicine and not just doing BS algorithms and assuming that they'll affect everyone perfectly, then I might not make enough money to pay back my loans.
Right.
And that is a genuine fear for these young individuals, and so they get wrapped into the system. So there's all of these financial impediments to good medicine coming at people from every angle.
Yes.
And I like to do conversations like this because what I'm really hoping to do is I'm hoping to encourage our colleagues.
Right.
I'm hoping to uplift them and tell them, hey guys, we can do better medicine. And you are a testament to this, as is Atma Clinic. You can have a functional business as well doing this. And then you align incentives. We can get great, astronomical, amazing, even unbelievable patient outcomes and still keep the lights on.
Right.
It's doable. But there does
and you'll
have to
enjoy
be a
doing
culture.
your job better. Yeah.
Yeah, absolutely.
Yeah.
So there really, I think, has to be a cultural shift where our peers start to go, I'm kind of sick of getting bossed around by all these managers and bureaucrats. Like, maybe we can do better. Maybe we can go back to being the scientist that I trained to be.
Right.
Rather than the tradesperson running the algorithm. I've got my little checklist. See you later. Ugh.
Well, and you take retail pharmacy. The problem with retail pharmacy right now is that you have these corporations that own these chains that they understaff their pharmacies, and then they don't probably pay them as well as they should, and then they throw in all these. It used to be the pharmacy didn't do vaccinations, but now they're doing all these vaccinations that they don't have time for it.
Oh, interesting.
Because they're understaffed already, and then you throw in all these vaccinations on them, it completely overwhelms them, and they get burnt out.
Yeah.
And I feel bad for them. And again, it's a situation where they pay a lot of money to go to school, and they go to school for a lot of years, and they get out, and it's the job satisfaction is very low from that standpoint.
Yeah, and people might be interested to hear that that's true across the board in healthcare. MDs, DOs, pharmacists, nurse practitioners, the satisfaction that us as practitioners, statistically speaking, in the system is incredibly low. And there's a very, very good reason for that. So, if any of you are listening to this and you're kind of like, I wish my doctor would kind of step up to the plate, it's like, well, it's hard for them too. It genuinely is. And so the future of healthcare to me is exactly what you said, Brad. It is the decentralization. It is going parallel.
Right.
I don't want to compete with Big Pharma. I don't want to compete with big insurance. I don't want to compete with big hospital. I just want to create something that works and gets really good results and let people vote with their feet.
Exactly.
Go where you want to, guys. This is fine. And I also increasingly am hoping that physicians and pharmacists and nurse practitioners and physical therapists and everyone else starts to kind of go, maybe I should go over to another system that is functional and lets me be a healer again.
Right. And so if the system allows you to do it and you actually are able to practice as an individual and help people, then hopefully what will happen is that other physicians will say, hey, I really want to do something like that.
Yeah.
Or they have the patients that are going to go, hey, if you really want to get help, go to this guy because he's really helping people. And then the other people that are doing the mainstream, medicine, it's not that they don't want to help people, they just don't have the time to help people.
Right.
And so they can practice like they feel like they should be able to practice and hopefully, keep the lights on when they do that and have a very successful individualized practice.
Yeah. Well, I think the future is bright. I think it's doable. And Brad, I thank you very much for joining me and sharing your thoughts, and I look forward to many years of collaboration forward.
Well, thank you, Neela. I appreciate it. Thank you.
Thanks for coming.
Yeah.